Good morning. Good morning. If you can come in and have a seat, we'll get started in just a moment. A couple of housekeeping items. One is we are taping today. You're probably hearing this announcement before, but if you will please turn off Blackberries and cell phones so as not to interfere with the taping, we'd appreciate it. A ticket announcement. The session at noon here at McNulty on Government 2.0 with Tim O'Reilly is at noon. They are misprinted on the tickets if you have a ticket. Do note that session is here in the McNulty room at noon. I'm Jay Loff. I'm the publisher of The Atlantic and here to introduce this next panel of distinguished members who will be discussing the human side of medicine. And to moderate the panel, a man who needs no introduction in these parts, I would say, Walter Isaacson.
Thank you. And it's a great panel. I've spent some time in the past few days with Gerard Kleisterlee, who is the CEO of Philips. And that means that he's a leader in the energy sector and the health sector, which is the two most interesting subjects we have going. So it's our great pleasure to have him as a speaker and a sponsor. And Tina Staley, it's Pathfinders, right? It's a wonderful organization she found dedicated to improving the experience of healthcare for those, especially with cancer. And a very old and close friend, Emanuel, who has been involved with the Aspen Institute as long as I have, at least, and is National Institutes of Health in terms of bioethics. You were a breast oncologist. And now you've been seconded to babysit your brother at the White House, right? to OMB, to oversee the health care. He's the smartest of the three Emanuel brothers.
I think the latest is nicest.
That is like being...
I know, it's damning with faint praise, right?
Yeah, being the nicest Emanuel brother is like being the highest mountain in Louisiana, where I come from. Not the hardest thing to be, but Zeke is definitely the nicest person I've met. So that's great. And I'm going to start with Gerard Kleisterlee with a very simple question. Tina is wearing one of those devices. Right. I got one of those devices. Most people here, since they've just arrived, don't know about those devices. Tell us about the device, where they can get it, and what it does.
Right. No. Human side of healthcare, that's what it's all about. I mean, we used to be a company that made diagnostic imaging equipment, and we still do. But that was, for a certain moment, our contribution to healthcare. And we have looked at the issues of healthcare around the world, and every government you talk to, whether it's in a developing economy or a developed economy, healthcare is in the top 3 of their issues for all kind of understandable reasons. And we said, how can we make a more meaningful, a more useful contribution than just allow doctors to make an image of whatever is the case with the patient? And that's where we looked at more holistically at healthcare and looked from the people's side. And we said, let's make it our aim to help doctors provide better outcome for their patients. And let's make it our aim to make a contribution to make healthcare affordable and accessible, but particularly also affordable for societies and governments around the world. And then, of course, you have to look at the whole cycle of health, which starts with prevention, that is, living healthy. And that's what this little thing helps you to do. It's called Direct Life. It's one of our new ventures. And it simply has inside a 3D accelerometer that just registers your movements. You hook it onto a small USB plug that comes with it. You put it in your computer, and you link to a website, and it tells you what your activity level during the day has been. You do that for a couple of weeks. It tells you what your pattern is. You give some more information, and you get a coaching advice on how you could adapt in simple ways your lifestyle just to live a healthier life. And we feel that looking at the whole cycle of care, starting with prevention, early diagnosis, proper diagnosis, intervention, and then getting home as quickly as possible is the way healthcare should be looked at. And that's why, as a company that is active both on the consumer side and therefore a trusted brand in the home, but also active on the professional side and a trusted brand for healthcare professionals, we can link healthcare with the consumer. And this is one of the ways we're trying to do that.
How do I get one?
Well, you go to the little Philips exhibition that we have here in the pavilion. You get one. You get a free trial subscription. You try it out, and when you like it, you take a subscription. And we're happy to provide you the coaching that you personally, because this is all very personal, that you need to adapt your lifestyle to become more healthy.
Specifically, it's in the Koch building, one of the rooms in the Koch building. It's a wonderful exhibit by Royal Philips that has imaging equipment and all sorts of things that the kids were playing on while you and I were having a deep conversation. I kept thinking, can I go play with all those devices behind me? So I urge everybody at some break to go to the Koch building, go to the Philips exhibition room, and get a free device, for which thank you. Do you think that, you said just now, getting people out of the hospital back into the home.
Yeah.
Is that both a cost savings
Yes.
and a way to help the patient personally?
Absolutely. Well, one of the early trials we did, because we're big in cardiac care. That's one of our strongholds. So we already some years ago did clinical trials with patients who had bypass surgery or so, to get them out of the hospital quicker. And what you see is that if you can put them under surveillance at home with remote monitoring, linking them up to their physician, in the home environment, I'm more comfortable. I recover more quickly than I do in the hospital. Rehospitalization is lower. So it is patient-friendly, and that's what it's all about. It produces a better outcome, and it reduces cost to the system. And that's one of the avenues that we're going with our home healthcare initiative. In care cycles like cardiac care, women's health, oncology, where we're focusing on, where we try indeed to bring the home into the healthcare equation, because it's clear. Somebody said some time ago to me, if you extrapolate the current trends in healthcare in the United States, in 20 years, half of the US population is ill from chronic illnesses, and the other half is needed to treat them. That's an unsustainable situation.
Wow.
And the good thing is that on one hand, what were deadly causes, cardiac arrest, cancer, become treatable conditions, but for some people they turn into a chronic condition with good quality of life. But they continue to be a burden to the system. And you can't treat a chronically ill patient only in a hospital bed. You have to make it manageable at home. And that's where the home comes in, and that's what we see as a territory where we have a right to play, and where we can make the link between the home and the healthcare professional in the hospital.
You know, when we think of Royal Philips, we think of the great, MRI and imaging systems. Have you shifted your focus?
Yeah. Imaging still represents around 30% of what we do in healthcare, but I think this year we will do $5-6 billion revenue in the US, where healthcare is our largest business. But we do it in-home healthcare with sleep apnea, respiratory, assisted living for the elderly, cardiac monitoring. We'll do it in ultrasound and patient monitoring. We're big in the ICU. So we have expanded well beyond the pure imaging. And we try to link our imaging increasingly with intervention. Yeah, because at the end of the day, it is about an effective intervention. And I would acknowledge that there is some pressure also in where the Obama administration is working. We've had the DRA. There has been some abuse in certain segments of imaging.
DRA?
Deficit Reduction Act.
Right.
Because there has been a huge rise of private imaging clinics where it was just about the imaging.
Right.
But
they seem to spring up on every corner now. Yeah.
A good physician does what's right for the patient. And in order to come to a good diagnosis, you need to do your imaging right. Yeah, but it has to be in the context of a good diagnosis, a good responsible doctor that says, yes, you need this test. It's not screening for the sake of screening. It's screening to produce a good outcome. And that's where we try to make the link with an effective intervention, because again, that gets you treated quickly, gets you out of the hospital quickly, and back into the economy. And that's what we need.
One more question before we move on. Tell me about the cancer pill type things you do.
You've heard about the eye pill.
That's right.
Well, of course, one of the issues in modern medicine is that medicine is becoming more and more personalized. And we have the ability, in the combination of modern molecular medicine and modern imaging, to monitor the effectiveness of treatment. So the eye pill is, you take a pill and we see where the pill goes and whether the drug that's in the pill does the job it's supposed to do, which greatly enhances the effectiveness. Because we know that of modern medicine, the pharmaceuticals we take, in particularly in cancer, we know that some drugs are only effective for less than 10% of the patients, but we don't know which 10%. Mm-hmm. And advancements in science, both on the imaging side and on the pharmacological side, and the collaboration between pharma and imaging companies will help us to make those treatments more targeted and therefore more effective and therefore a lower cost burden to the system.
But how does the pill work?
You swallow it and it has a small tracing device in it.
So electronic?
Electronic, so that you're able to monitor how it moves through your body. And of course, that what you don't need will come out again.
Great, okay. Tina, talk about the other side of the equation. We talked about the technology, but also making sure that the patient who gets to go home, gets to be in a better environment. With Pathfinders, you're really trying to take care of the human side and not make it all about the technology of treating cancer, for example.
That's correct. And, as I'm listening to you, it really strikes me in terms of dealing with the fear and the anxiety that really accompanies a cancer diagnosis and treatment. So what we obviously do is go in and really teach the cancer patients and their families coping skills on how to get through the process. And one thing I wanted to go back when you spoke about the scans, I think that's in the ideal world, and I know a lot of physicians that really do give the right scans, but there are a lot of occasions where the patients are so anxiety-driven that they really are basing their entire sort of am I going to live or die based on these scans. Mm-hmm. So I think it puts the physicians oftentimes in an awkward position when you have the patient really demanding a scan because the anxiety is so great. And so there oftentimes they say, I'll give it to you, when it really isn't necessary. So in the work that we do with Pathfinders is really in an age where there's a lot of prescriptions written, a lot of scans. We really help the patient deal with the issue that's underlying all of these particular types of interventions. So by actually working with them on their despair, their distress, their hopelessness, their helplessness, then we're actually able to bring them to a place where they can make the right decisions in terms of what is best, not based from fear and not based from a sort of desperateness, but from much more of a personal recovery, giving them the tools to cope that they need. And so when we feel that they have this, the patients and their families have this confidence, then I think that it reduces the sort of anxiety that accompanies this, whether it's going home and having to depend on particular systems and hoping that they really work, and it could be life and death if they don't. So we do the sort of mind-body, the cognitive restructuring, different tools that we have worked with and shown that it works.
This is supposed to be about the human side of medicine, so let me ask the human side of Tina, which is why did you get involved in this? And I know you had some family involved that sort of led you down this path of Pathfinders.
Well, I spent 4 months with my brother in a bone marrow transplant ward in Seattle. And it was during that period of time that I got in touch with the loneliness and the isolation associated with this. I'd see a young girl sitting with her single-parent mom who was dying, and there really wasn't anybody around to help her through the system. And I said, well, we have the best technology, we have the best medicine, the best science. We are really, really not taking care of the human spirit. And that's when I formed this organization with Krista McDermott, my Pathfinder partner, because when I got recruited to go to Duke, it was interesting because I walked through the hallways, and I love Duke, I love everybody, I think they're great. But you looked in the patient's eyes, and the terror and the fear at times, I could have been in India, you know? I mean, so I think that we've missed out a lot in terms of humanity, and really technology's been fabulous, but I think we have sort of gotten away from basically connecting with each other.
And how does that help the patient care? I mean, does healthcare work better if people feel that their entire social and mind and body and spirit are in better shape?
Oh, absolutely. I mean, our research on basically our pillars was hope, self-care, support, spirit, life review. What it really showed is that I work with all advanced stage cancer patients. And what it showed, that as they got help with coping and learned these mind-body interventions, that actually their distress and the despair and sadness got actually much better, even though their symptoms were getting physically worse, even into end of life. So they perceived their quality of life after learning how to cope better, even though their physical symptoms were getting considerably worse. So,
you know, it's a philosophical thing almost, which is not only are we supposed to prolong the end of life, but we're supposed to make life better. And sometimes we do better at the former, prolonging the end of life, rather than making life better throughout, you know, the end. So, I mean, is that, and so give me some examples of what you do to make that work. I mean, you touched on them briefly a moment ago. Well, to make the feedback, the spiritual feelings, the coping mechanisms.
Yeah, what we do is we combine Western psychology, which is our thoughts, because we believe that so much comes from our thoughts. So if you become obsessed and you think, oh my gosh, you know, am I going to live? Then you're locked in fear, and then somehow physically it comes out, which often comes up to the doctor's office in physical symptoms, by the way, when the back's aching, when really you're terrified you're going to die. So we work on changing the thought process, and we combine that with Eastern philosophy of working with the mind, the body, the spirit through visualizations, music, relaxation techniques. So we've really found that the combination of these two, and we have a very structured model with interventions that we have been able to match to your coping style. So by using these interventions, that's how we have gotten the evidence base in our research that proves that it works. And I mean, it's just amazing. Especially in end of life, I have patients call me as they're dying, and they were terrified to die. Of course, nobody liked to address it. And then once we worked with these interventions, as they're dying, their last breath is, it really works. I am at peace. And I hope I didn't mess up your research if I die. But that's the importance of our thoughts on this entire system. So fortunately, I work with electronic data collection. With every patient, when they come in, I'm able to record their psychological symptoms and their physical symptoms. So the physician and myself look at them from a whole person perspective and can see how one is working with the other. And I think that's the biggest disservice in healthcare today, is that we are not looking at the patient from a whole person perspective of how one impacts the other, but most likely from a medical model.
Can I give another example, Walter?
Absolutely.
On exactly that
yes,
point.
Gerard.
We started working a few years ago with one of the doctors in Lutheran Children's Hospital in Chicago. And what we noticed is that when children, cancer patients, had to go through a CT scan, they were scared. So that they were uneasy, they were moving around. The scan had to be redone, which is additional doses, slowdown in throughput, etc. Then the solution is, we will sedate the child. Go as a mother with your child to the hospital and see your child being sedated with all the anxiety, will he wake up? Yeah? So we said there must be a better solution to that. So our designers started to look at how the whole procedures were going on, and they designed an environment And you can see it in our exhibition here. Actually, we have an example.
saw it, yeah.
We designed a kitten scanner, which familiarized the child with the process of going through a CT. We designed some tools whereby the child could choose its own environment. He could take a cartoon character, and the examination room would be transformed with light, with audio visuals, into his environment. So this would put the child in charge of the procedure rather than the hospital or the doctor in charge of the procedure. And the results, and there's a lot of clinical evidence of that, it all has been measured, is that children were more at ease. Sedation levels went down dramatically. Throughput for the hospital was increased. Dose for the patients was lowered. And we had crying mothers that were so happy that, because you have all these repeat patients. This is the human side of healthcare. And that's where, for us, innovation, there are three elements in innovation. That's marketing, obviously, that's technology, there's design. Design does the human side of research. Mm-hmm. And combining technology with the insight that our designers have creates a people-friendly environment. And we've taken that now broader into the hospital. You see an example of how we've redone Disney's Children's Hospital down in Florida. Totally from that perspective. Because it's all about the patient and putting a doctor in a position that he can take best care of the patient.
You've spent your life tying together the human side with the medical and technological side. How are you doing it now that you have to go into the White House?
Well, first of all, I think most people who know me would be surprised that I'm on a panel about the human side of medicine. So I think that I would say my bottom line is that we have, for the last 50, 60 years since the end of World War II, and our very big investment in biomedicine through the NIH and others, have really emphasized high technology medicine, whether through organ transplants or intensive care units and all the advances. And I think we have lost the high touch part of medicine. And I think part of what we need to do over the next decades is to shift from high tech medicine to high touch medicine, where technology at best supports, but doesn't take center stage. I do think that the last 50 years, and the reason this draws so many people, and you even have the theme here, is because we really have been focusing on the high tech as opposed to the high touch. And I say this as now a newly minted green eye shade guy at OMB, not as a humanistic doctor, because if you look, the real challenge for the healthcare system is, can we get higher quality at lower costs? That's the holy grail, and how do we do that? And if you look at where the high costs are, they are in chronic illness, coronary artery disease, congestive heart failure, emphysema, diabetes, asthma,
Cancer.
And cancer. Those, if you take those 6 diseases, those are very expensive, and the main expense is we don't do a good job of keeping those people healthy and out of the hospital. And then there are a whole series of procedures where we have a lot of discretion, knee replacement, cabbages, coronary procedures. And those 2 buckets are where we really need to focus our attention if we want this high quality at lower cost. And then you ask yourself, well, how do we get those combinations? How does it work that we can get high quality at lower cost? And one of the things that happens, if you look in the literature, almost all of it involves high touch rather than high technology. And let me give you sort of 3 streams of data, since I'm a data-driven guy, on this. If you look at companies that have done a lot of intervention on their workers and gotten them really healthy and reduced their healthcare costs, reduced their disability costs, improved their performance on absenteeism, so it's the Johnson & Johnsons, the Pitney Bowes, those companies, almost all of them, have put in some on-site, high-touch care. They've got doctors who are spending 20, 30 minutes with people who have chronic disease at an appointment. It's not the 7 minutes or the 8 minutes. It's a lot of time. And then they involve them with the team, including people like Tina is talking about, people who talk about their life and their lifestyle, because it's that way that they can get lifestyle changes in these people, more exercise, better eating, etc. Similarly, so that's on-site docs. Similarly, if you look at the so-called disease interventions, disease management, the only ones that work are the ones that are face-to-face, people-to-people, more human. The technology, the robocalls, the computer-based stuff, no effects. It's all face-to-face interaction that is the catalyst for moving people to take control of their own life and
Well, let me interrupt real quickly because Gerard had said about getting people to the home and monitoring them remotely. How do you square that circle?
So I think that's exactly the right thing. So technology can help in some of these cases, but it should never take center stage. So, for example, I don't know whether it's your company or other companies have these pill boxes where they're radio controlled so that if a patient doesn't open it, isn't taking their pills, goes back to a central monitoring, and then some person who they trust can intervene. Or as you point out, other people have produced scales for people who have heart failure, and if they're gaining weight, it is recorded to the hospital or their loved one, and they can intervene. When technology takes center stage, we almost always lose the patient. When technology supports this idea, I think that's when it's going to be successful. That's when we are actually going to be able to have this higher quality at lower cost. But I also think it's quite important that we have what we need is the right use of technology, and we also need technology that actually drives down costs. Medicine is one of the few places where more and more technology actually has increased costs. I mean, 50% of the
But how do you get it so that technology drives down costs rather than says, here's 20 more scans you could possibly have, and thus it's 20 times the cost?
Well, I don't want to be a reductionist about this, but it is, I wouldn't say all, but predominantly in the financial incentive structure we have, right? I mean, right now we're paying doctors to do more. So take the hospital that Gerard was talking about. You get patients out faster, or you get fewer patients, fewer scans, you can charge less. Well, what hospital is going to put themselves out of business, basically, or put themselves into the loss category if they get paid for doing more, and you're telling them it's better to do less? So we have to change that financial incentive. And one of the ways is to say, all right, you're a good primary care doc, we're going to give you a pot of money to manage patients, and we're going to help you figure out, we're going to give you some guidelines as to what to do, and we're also going to help you manage the patients better. And I would say that one of the things, and it was really interesting to hear you mention it, one of the things we have done woefully badly in the medical system so far, and I think getting better, is this whole design piece. Because almost everyone who looks at physician offices or hospitals says, redesign will save you a lot of money. Just redesign the system to be more patient-centered and patient-friendly. And there's a huge amount of money there. I mean, there we're talking about tens, if not hundreds of billions of dollars.
Gerard,
no, it's right. And one of the successful places where we have implemented, for example, this early release from the hospital in remote monitoring is by collaborating with the insurer. Because that's of course, you need the caregiver, but you also need the insurer.
Right.
And that is one of the ways to get efficiency into the system. The other thing we need is more of what we have in industry, that is best practice and benchmarking. Because most doctors are self-employed, private physicians. They think of themselves more as artists than as artisanats. Mm-hmm. And there is something like established best practice. There is a best practice way of treating a cancer patient or somebody that needs a bypass. And why shouldn't that be proliferated? Yeah? Mm-hmm. And also there, insurers are the ones that have an interest to enforce that. And we see that some of the most successful hospitals are the hospitals where the doctors are employed.
That's one of President Obama's pushes, right, to get best practices, data-driven medicine.
Yes, and I think there's a big tension in our country. Every time someone hears best practices, they say cookbook medicine.
Right.
And I think that is a big tension in our country. On the one hand, we do want a physician who is going to be personalized and aware of us. On the other hand, almost all of us who study the area do think we need more standardization. We need more best practices where doctors aren't freelancing based upon what they learned 20 years ago.
Yeah.
And
do electronic medical records, in your opinions, help on that? I mean, where we could sort of data mine what works, what doesn't, and in some ways monitor what physicians are doing.
Absolutely. But we shouldn't think of it as sort of this holy grail that is going to solve everything. For one thing, it's very important to recognize that again, not designed properly, it'll come between the patient and the doctor. A lot of complaints that patients have is if doctors have a electronic record, they're actually looking at the computer, not interacting with the patient. Very bad. Okay, so one of the issues we got to do is to figure out how to have the electronic record without interfering with that relationship. Otherwise, we have another case of technology taking away the human side of medicine rather than augmenting it. The second thing I would say is that we need to be careful. One of the problems, again, is this issue of how to get information and guidance to doctors at the time that they're making decisions with patients. And I think we don't have a very good system for that yet. Some places have, I think, done better, but I don't think it's. I think it's a place where more research, more work on design, more work on how alerts intersect with decision making is going to be necessary.
Yeah, and more work on tools for clinical decision support, because there's so much information coming at the doctor that drawing the right conclusions from all that information also is becoming increasingly difficult.
Mm-hmm. Tina?
I'm really glad that, first of all, you said that, that human, that one-on-one contact, you can never replace. And also when you mentioned in terms of the physicians and sort of being in their electronic data collection, because I've really seen that so much of that contact has gotten lost. And also when we speak of scans, going for the scan and possibly not spend as much time speaking with the patients or even doing physical exams. So they're really hungry for that touch. And I also say that in terms of dealing with individuals like myself that can help you with the system, can also be cost effective. What we've noticed, and now we're going to start a research project around it, is that individuals that are learning how to cope and getting their psychosocial needs taken care of actually have less emergency room visits, less phone calls to the physician. We're able to get them into hospice an average of 3 months just within our work earlier, and less drug prescriptions. Because what's happened because of a 15-minute interview with the patient, they go in and they write a prescription and like that, not even really looking at the whole person, write the prescription instead of sitting down and just chatting with them.
That's a really good point. And if you're going to do cost containment in healthcare, it seems you also have to deal with the patient who immediately wants, when anything's wrong, give me either a pill or a scan. I want you to write a prescription. I mean, how do we? It's almost a sense of rationing. I mean, that word is a horrible word, but you have to say to people, no, you don't need that scan.
But that's not rationing, Walter. I mean, what that is...
Rationality, maybe.
Right, exactly. What that is the doctor taking the time to guide the patient. Patients, they do demand things, but they also, I mean, almost all the data shows this, overwhelmingly look to their doctor for advice. So if the doctor says that is unnecessary now, yes, some small fraction of patients are going to push back. But most patients, including highly intelligent patients who tend to be the more demanding ones and the more educated ones and the more informed ones, listen to their doctor and listen to what their doctor is going to tell them.
Well, what incentives does the doctor have to say, I won't write you that prescription, I won't give you that scan?
Right. So now we're right back to the incentive structure that operates for doctors and patients. And that's why I think that over the last 50 years, in addition to the development of technology and the sort of training of doctors, we've created an incentive structure that encourages doctors to do more. And it's just that simple. If you're an orthopedic surgeon and you get paid to put in that knee, right?
Yeah.
Now, what is the incentive for you not to put in the knee when there's a judgment call, right? So rather than talk to patients about, other ways of approaching it, your incentive structure is to put in the knee. Or similarly with a diabetic patient, your incentive may be not to talk about lifestyle changes. That's a long haul. But here's another medication. Exactly.
But let me ask you. Oh, go ahead.
I want to just raise one other issue to pick up on what Tina said, which is, again, I don't want to overplay J&J at the cost of other companies here, but one of the things that's interesting is if you go to them, and they've been in this sort of healthy workforce for 30-plus years, they've been working on their workforce, and they've made dramatic strides. Recently, they bought 2 behavioral health companies, initially to work with their employees, not to sell product out there, because they noticed that one of the big barriers, I mean, they've been able to improve health a lot, but there's a residual amount which is very much about behavioral medicine, whether it's depression, anxiety, preoccupations, and other concerns. And I think a lot of the data show that depression, especially situational depression and anxiety, do drive a substantial amount of cost. And so medicine has sort of divorced the psychiatric side and sort of looked on it as a sort of second-rate
That's
field.
what Tina is doing.
Right.
Yes, yeah.
And I think part of what we're seeing now, again, is the need to bring in both sides to really manage patients with physical illness. We are not just bodies, as it were.
Yet 50% of cancer patients 1 year after diagnosis show symptoms of clinical depression. 25% shows symptoms of clinical depression 4 years out.
Gerard, do you worry that a new healthcare regime that has different incentive structures will tell people to get less imaging or less technical intervention?
I don't worry. I mean, I worry when I hear that the perception is that technology drives up healthcare costs. I think technology is there to help contain healthcare costs. And for me, the simple comparison is our healthcare in Europe is not much worse off than healthcare in the US. On the contrary, I would say in Europe, everybody has universal access. That's not the case in the United States. Europe pays average 10% of GDP for healthcare. The US pays 17%. So something's wrong in the US. And
Let me just, for the audience to know, Gerard lives in Amsterdam, right?
I do.
Yeah, I mean, I didn't mean it as a joke. I just, people saying, okay, where are you?
And in the Netherlands, we pay 9% of
Yeah, right.
on healthcare.
Right.
And yes, there has been in some areas, you could say some abuse of imaging. But that's only a minority. If you look at technology, all technology represents less than 10% of healthcare cost. 90% is in staff, is in medicine, and of technology, imaging represents 2%.
Right.
Yeah? So what are we shooting at? We should be shooting at creating a more effective system with the right incentives, indeed, to do the right thing for the patient. Yeah? Incentivize doctors to do what's best for their patient and to produce good outcomes. And that's our attitude towards healthcare. We think that's in the interest of societies, also in the interest of society here. So from that perspective, I'm not worried. I see that as a necessity. I see it as a reality. And if in the process that leads to the fact that we will sell one or the other fewer MR, then so be it. But I think in other areas we will be able to make a much better contribution. And that's what, at the end of the day, also our business is about.
So I actually, first of all, it depends how you define technology to say that, I mean, drugs are technology too, devices are technology,
Okay.
hip implant. So almost all the economists who look at it, 50% of the cost increase in medicine is technology driven. And very little, it turns out,
No,
includes drugs.
Okay.
Very little of it.
When I talk about technology, I look
Yeah.
at the device side.
Yeah.
I'm not looking at drugs or implants.
Well,
no.
it's all there.
Yeah.
But very little, actually, for example, is aging of the population. Almost very little of the drive up in healthcare costs is that. The problem is not technology per se, right? I mean, we have, look, this technology, right? It's driven down costs, hasn't raised costs. Only in medicine has technology driven up costs. And that's partly, you invent something new, and there's no incentive to price it down. And all the incentive is to price it higher and higher and higher. And so we haven't created an infrastructure, the financial reimbursement and economic infrastructure, to actually develop technologies where the prices go down. I think organizations and companies like Philips and all the great innovators, I mean, is it impossible to develop new technologies that do more and are cheaper? No. We know that in telecommunications and computers and all sorts of areas. Only medicine stands out because of the kind of payment system we have, where that's not the incentive.
Gerard?
Once we change the incentive, these guys will make a lot of money making things better and cheaper.
No, I think I fully agree. It's a matter of incentive.
And innovation won't go
If
away.
We need a more effective system because we have a growing population, we have an aging population. So globally, there will be a huge demand for more health care. Yeah. That's a great opportunity for all of us. If in the context of that, we also can deliver better care at lower cost, we will still have a great business and we will make a useful contribution to society.
Let me open it up, please. Yes, sir. Just shout it. I know we have microphones if you have a weak voice. But
we want to know who they are.
tell me who you are and...
I'm a child psychiatrist and the head of the worried, as all doctors are, about lawsuits. And many of the times, the reason why they do blood tests or they do scans is because they are worried that the legal system will come back.
Great question, and it deals with lawsuits. And
All right.
the OMB guy here from the
The green eye shade guy. First of all, lawsuits and the defensive medicine, at best, assessed pretty rigorously, is at best 5% of the system. Now, I agree with you. It's got a big psychological impact on doctors, way out of proportion to its effect on the actual healthcare system and its driver of cost. And I think President Obama has made quite clear that that has to be addressed as part of healthcare reform more globally. But I have to say to my colleague doctors, I think we're overly obsessed about this problem. Again, if you look at the lawsuit issue, what's the number one predictor of a lawsuit? Terrible relationships between the doctor. The loss of high touch. You go to high touch, even if you're a crummy doc and you have high touch, you're protected. So, I mean, I do think we need to have this revolution in medicine that we're really focusing on the patient, and that is going to solve a lot of these other problems.
But what is Obama going to do on the lawsuit? You said he is going to address it.
He has said a number of times publicly that he is interested in solving malpractice, and I will be fired if I say more.
Yes, ma'am.
Jan Hamilton. I'm president and CEO.
You have a job for me?
Yeah, sure.
Nutritional biomedicine. As we look at global wisdom related to healthcare, we heard yesterday who's footing our bill. China is paying our debt. Now, in China, the doctors who make the most money are the ones who keep their patients healthy at a low cost. When will we adapt that paradigm in America and tap into that global wisdom of prevention, of keeping people with a high quality of life, low-cost health care as we age?
Let me have Gerard and Tina talk about both prevention and then the larger issues of your question. Gerard?
No, I think here's the example. We start with prevention. In our consumer business, we focus at health and well-being. We try to get away from the electronic gizmos that we used to do years ago, and bring more and more propositions that support a healthy lifestyle. We go then all the way into the, let me say, hardcore healthcare, and bring the patient as early as possible back into his home environment to live with a chronic disease at good quality of life, whatever. So I think we're very much focused at doing things that support quality of life in a healthy lifestyle and in good treatment, quick recovery. That's how we have positioned ourselves, and we think that that's where the future is, because otherwise healthcare is unsustainable in the way we do it today.
Tina, you're the expert on Occidental, Oriental learning.
Yeah, well, when you talk about prevention, I mean, obviously you have the technology, but it really is the changing of the lifestyle. So when you look at the obesity rate in this country, it's absolutely ridiculous. So I think companies like yours, what are you doing to give the incentive for people to go to lose weight, those type of programs? Obviously less disease, we all know, the cost, all of that. So, you know, to me, it's not only working with them in terms of lifestyle, but it's working with them to get a plan that's actually going to be sustainable. Nothing that you do, let's go after New Year's Eve to the gym, sign up for this, let's do this, but you really need to have a comprehensive plan or it won't work.
So can I say, first of all, we need to distinguish primary prevention, which is preventing people from getting a disease like obesity or diabetes or heart disease. That is not a doctor-driven part. That has to be driven public health, cultural issues. And, you know, we've seen things like smoking cessation that we can actually make a big difference. You know, this country's gone from, in the 60s, 49% of the population smoking, adult population smoking, down to 20% now, lower than any place else in the developed countries. So we know that's a public health intervention. The best ways are not doctors, it's raised taxes, it's public health campaigns, et cetera. Then their secondary prevention is once you have a disease, keeping you as healthy as possible. So if you have diabetes, changing your lifestyle so that you're exercising, eating right, et cetera. That is more doctor-driven, and as I have said, that's really best done by high touch. But there you need to pay doctors for those kind of outcomes, and incentivize them and give them the time to do it. And that is not compatible with paying them on a piece rate basis. I mean, it's just that simple.
Yeah, that's what you said. Let me get the gentleman here, and then I saw you. And yeah.
Yes.
Barry Stroud, yeah. Which hospital?
Inova Fairfax.
Okay.
And there's a revolution that I've observed going on in our hospital. I know what's going on across the United States, and the majority of people in this room do not know about it until it affects them. And none of you have mentioned it, and I want your comment on it, and that is the concept of hospitalists. And it starts with the primary care physician saying, I will no longer come to the hospital. And you then have a division between care out of the hospital, care in the hospital, and it is now spreading to the specialties of surgery as the next place that it goes, so that the neurosurgeon who sees you says, I'm not going to actually be the one taking care of you, a hospitalist will, which means somebody without expertise as a neurosurgeon who see a divorce that starts between the primary care physician, then the hospital, and then the specialists. And it's very scary. It's cut down the flow of physicians into primary care. And by the way, I've not yet observed it in oncology, but I'm sure it's coming.
No, I'm sure it's not coming for lots of reasons. People are scared about all the drugs we use. But I actually disagree with you. First of all, I don't think it's all that new a phenomena. If you look at the Mayo brothers, when they set up the Mayo Clinic, they wanted to work in the operating room. They were surgeons, and they brought in a bunch of doctors to take care of patients before and patients after. They didn't call it hospitalists then, but it looked a lot like hospitalists. I actually think it's it can be a bad thing, but I think properly deployed, it's going to be much better, because you do have people. We know that if you do the same thing over and over again, the higher volume makes higher quality, and you want people to do that, have that kind of expertise, rather than, cover the gamut where they're not necessarily keeping up to date in all aspects. It can be deployed badly, and I agree with you there. The real issue about primary care, and the reason we have a primary care shortage in this country, is purely and simply dollars and cents. If you just look at what primary care docs are paid, and you look at what a specialist is paid, you want to know why the primary care doctor is not in lifelong therapy, because it makes no sense from any standpoint. Satisfaction, economics, work hours, etc. It's lunatic the way we've structured it. And again, President Obama has made this very clear that that's got to be redone under healthcare reform, in part because we know that primary care doctors are the best way to keep people healthy and to get cost-effective care to people.
Hi, thanks. Ellen Sabin.
Hey, Ellen.
So on the public health side, you're all talking about public health and high touch. And I'm curious how much from both a budgetary standpoint and a focus standpoint we're putting into initiatives in communities to reduce obesity, educate kids about proper eating, all that sort of stuff. And going along with that, curious if some of the initiatives in community levels, like mayors or governors who are trying to say that they're going to reduce the obesity in Oklahoma, how those are working. Are those efforts working?
So two things. President Obama, in the stimulus bill, in the Recovery Act, there's $1 billion for prevention, and it's basically to take proven community prevention techniques and to disseminate them. And so we're very committed to it, and I think you're going to see a lot more of it. You're also going to see the reauthorization, sorry to be so technical, but of the school lunch program, which has been heavily criticized for not giving kids a very nutritious lunch, and that's going to be refocused. President Obama has also charged a group of us, of which I'm a participant, to look at the wellness of the federal workforce and to try to get some best practices implemented at the federal workforce site so that companies can look at them. And what was the last part of you? Oh, the mayors. So the best example of trying to combat obesity on a statewide basis probably is in Arkansas. They have a terrific Surgeon General there, Dr. Thompson, and they do body mass index measurements of school-age children so that they take their height and their weight. They send it home to parents. Over the last 5 years, they have stabilized the obesity situation. So instead of going up like the rest of the country, it's stabilized. Although I will say it's stabilized higher than, because it's the South, higher than.
Hey.
Just facts there, Walter. Just the facts. Stabilized in Arkansas. And part of what you find out is that a lot of us have this sort of social reorientation. A lot of parents did not know that their kids were obese or overweight. And that's partially because they see other kids, and you compare your kid to other kids. And if everyone else is overweight, you've renormalized in your mind. So that has helped. That is one method for helping. And they're sending home information to parents about what they can do, how to intersect with their doctor, but also how to eat better. It's a very good model. Is it the solution to everything? I think it's a very good start.
Yes, sir.
Jerry Stein, medical school
Yeah.
professor in psychiatry. Medical care is much less effective and less efficient because doctors don't talk to each other. They don't talk to their patients, other physicians, their patients' ancillary therapists. In part, that's because there's no financial incentive. Are you going to fix that?
You keep getting the questions, but...
Am I going to solve this? I notice how this is turned into healthcare reform, which I'm not supposed to be talking about. So there is, again, a big commitment to having more coordinated and integrated care. And part of that is, Gerard mentioned, we have doctors are onesies and twosies. I think it's 2/3 of American doctors are in groups of 4 or less. And that does create a big coordination problem. And we know that bigger groups, more integrated, where doctors do have an incentive to communicate, works better. So the electronic medical record should help in this, but it's by no means a complete solution. Having financial incentives that encourage doctors to coordinate and integrate, getting rid of legal barriers that prevent that, those are all on the agenda, and we're all quite well aware of the need to do them.
Yeah. Tina, and then the gentleman back there, and then, yes, I see you. Yeah.
And I also see that doctors are under so much stress. I mean, they're having to handle difficult issues all day long. They're having on their own lifestyles, working on how to cope. Not only is there not time, but when they get together, they want to just handle what they have to deal with, and they want out of there. So, you can do all of these type of things, and that works, but you also have to understand the burnout rate. And I think that they need to be addressed from this sort of healthy lifestyle just as much as the patients.
Mm-hmm. Yes, sir.
Thank you. It's Art Kleiner, editor of Strategy and Business. This is not about healthcare reform. It's a very human question. As you were, mostly for Tina, I guess, but as you were talking, I kept thinking of Yeats's lines about raging against the dying of the light. Does this broad scale, well, the link between depression and cancer is understandable. And does this kind of reform on the broad scale depend on people giving up what is a very natural human reaction to not accept the burdens of reality, let's say?
So what is this? I didn't quite...
The question is, don't we have to accept the burden of reality, that the dying of the light happens, and how do we get people to accept that? Is that
yeah.
In other words, if reducing costs depends on breaking the link between depression and cancer to some extent, and that sounds like a tremendous attitude and behavioral change that's very personal and very individual, and how do you
Well, it is
think about
personal and individual, and I think that, in other countries you deal with end-of-life issues on an everyday basis. But in this society, when we are basically, conditioned that we aren't going to die. I mean, we really think on some aspect we're not going to die. So therefore, when the issue and the elephant in the room is not being addressed, physicians, for understandable reasons, it's a difficult issue, don't want to speak about end of life or dying until the last 3 weeks, of which I'm working with them, but I said, can we start talking about it maybe 6 months, a year early? They said, you've got to be kidding. We don't deal with that till the very end, till hospice. So when we're actually not dealing with the elephant in the room, with these underlying issues, and people really want to, but all they know is to go in and to talk about the, quote, diagnosis. That's what they are being conditioned to do in this society. So it is a natural, process. We're all going to die, but for some reason we have this stigma against speaking about it. And so I really think there has to be more of a societal change and being willing to discuss the difficult issues.
Yes, ma'am, right here in the middle. Yeah.
Okay, Terry Davis, LSU.
Yay.
Medical Center.
LSU Tulane Medical Center, please.
No, Shreveport.
Oh, Shreveport, okay.
Okay, not New
Sorry,
Orleans.
enough fights.
Okay, this is for Zeke. If you were the king of healthcare reform, I suppose.
They usually kill kings. I'm not sure I want the job.
Okay.
Czars get beheaded first.
But here's what is your vision of how a physician's office would operate if there was incentive to talk to patients, to spend the time to actually talk? Is it the physician? Is it an extender? How does this go down?
Yeah.
Let me also, if you don't mind, I want Gerard in on this too, because
sure.
it's not just a policy issue. It's what would be your vision of the doctor's office of the future?
I think that and we see that in Europe, and probably you all see that also here, that we need to go back to a situation where there is a bigger role for the general practitioner. Because the general practitioner has to provide the first screening, has to provide the recommendation on which specialist to see, where to go, to which hospital to go for a treatment. And so we have to to recreate a situation where it is attractive to be a general practitioner. I think that's one of the big issues that not only in the US, we have the same issue in Europe. We need to recreate a situation where it is interesting, rewarding to be a general practitioner, because they are very important in our care system.
And how are you doing that, with your company?
Well, we're also looking for ways to link into this, because as the home is starting to play a bigger role, so has the general practitioner, because he's the first link with the home. Now, so we're also looking for ways to get more in touch with the general practitioner through a number of these things that we do. We work on independent living for the elderly. There we need to link with a general practitioner's home. And we try to facilitate also the link between the hospital and the general practitioner with some of the technology support that we can offer.
Yeah, almost everyone who looks at this, I think, concludes that you have to have a team approach. And the doctor is a member of a team, but you need a care coordinator, nurse practitioners, linked to probably good home health and other support. Now, that's very difficult to establish in a practice of one doc. There's not excess income to support that. You can maybe buy a piece of it. So in some cases, what's happened in North Carolina and Vermont, they've begun to establish community support coordinators for going out and working with people with chronic illness to support the individual practices. But I think over time, we are going to have to see more integration and probably more bigger groups of doctors working more closely together. It's probably an area where we still have the 19th century model of individuals, craftsmen as doctors, and we need to have a little more larger groups that can do more of this activity, pay for the electronic record, pay for nurse practitioners to help, maybe even pay for pharmacists. I mean, one of the big interventions that if you go to these physician practices that have really scored well on this high quality, low cost, they actually distribute their own medicines. One of the biggest problems is patients don't fill their prescription, and then they don't know what to take. So one practice in Boston, for example, has taken all the drugs and put them in preset cases with a little sun and a little moon for their elderly patients. So these are the ones you take in the morning, these are the ones you take in the evening, and they actually repackage the medicine and give them out. That group also, which I trained under when I was at the Beth Israel in Boston, they used to drive us nuts. One of their patients would come into the emergency room. They would come zooming into the hospital, the doctor himself, no matter what hour of the day. They prevented more hospitalizations because they knew their patients so well and they knew what they could send them home to do. And that also, the idea of either making house calls or the doc showing up in the emergency room to handle it and not just rely on the emergency room doctor who doesn't know this patient from Adam, is again another element that probably can only be done when you have larger groups and you have more extenders. So I think that's an inevitable part of the evolution of medicine.
Let me get Tina in on this, which is, suppose you have the larger groups, the physician practitioner groups, and you said that would allow them to get into providing the drugs. doing the electronic medical records, having the nurse practitioner. Should they also have sort of a Pathfinder type counselor as part of a regular physician's practice?
Well, absolutely. I mean, you're talking also about healthy lifestyle. So you're having to have coaching in terms of their exercise. This is perfect, you know, in terms of their healthy eating. And then you're, once again, having to teach them the coping skills. Why is it we buy a blender, we get a 100-page manual? We get cancer, there's no manual on how to get through it. So you need to have that one-on-one person, you know, that or groups or whatever that allows you to be able to deal with this from all of the different mind-body perspectives.
Mm-hmm. Way in the back, the furthest person in the back there, and then the second furthest. I'll get you next, ma'am. Shout.
I wanted to get, John Horton, private investor. I wanted to get Ezekiel to comment on something that Gerard said that I thought was very interesting. He said that Europe spends 10% of the GDP on healthcare. We spend 17%. He thinks we've got similar benefits. So the question for Ezekiel is, one, do you think that's right? And two, what's in that 7% delta? Thank you.
This is only a matter of facts. Of course it's right. It is a matter of fact. In general, Europe spends somewhere between 8 and 11 or 12%. I think
of GDP.
Of GDP on healthcare. Switzerland is at the high end. And we do spend 16, 17% on a trajectory, actually, that is breaking away from Europe even more year to year. So over the last 4 years, our spending's gone up faster than Europe's has gone up.
What's in that 7% delta? Yeah,
that 7% delta is we do more procedures per capita, so more knee replacements, more heart catheterizations, more CABG surgeries. We have higher costs, so if you look at our drug costs, we have higher drug costs. We have higher costs for the knees that we put in and the devices that we use. Our physicians are paid more. So we have created a system which is just overall more. So we do and have...
Does that give us more health, by the way?
Absolutely not. Okay. There are very few metrics on which we're better and lead the world, including developed countries. There are many metrics in which almost every other country does better than us. And heretical statements in some areas, including cancer treatment, which you would think we would be leading in, a place like Cuba does better than we do on a few cancers.
So what's your next job, by the way, since you just lost the... Sorry. Yes, ma'am, right there, yeah, sorry. Oh, hey, Jan, how you doing?
Hi, local psychotherapist. Those of us in our community here are so frustrated by the disjointed mental health care. Could you let us know what the administration is doing about mental health care, and are there any changes that we can be looking forward to greatly? Thank you.
I don't know if I can say anything on that. I think I'm going to...
Yeah, I mean, I do have to protect Zeke from...
Even from his own tendencies.
Making policy announcements before the president does. But, Tina, did you have something on that?
Well, I don't know what Obama's going to do about it, but it is a real crisis in this country in terms of...
Do you want to make a general statement on how you see the problem?
Well, I think that if you look at the problem and you look at healthcare, we know that a substantial portion of people, especially with chronic illness, have mental illness components to it, whether it's depression or extreme anxiety and other things. And so dealing with that is going to be important. And putting it, again, into the whole package is going to be important. You're going to see these services probably as, part of a basic benefit package. But the issue is less what are we going to do about it, but how, once we have insurance companies and others that are going to actually manage the interface, how that is packaged in terms of payment.
But also finding the right interventions for mental illness, too. I mean, you're doing a lot on the other areas, but you also need to do the research around what works.
Yes, ma'am, and then yes, sir. Actually, all three of you, so we'll keep in the middle for the moment. Mark, okay, Kay. Kay Bucksbaum, and then I'm waiting for the microphone to come up.
I have not heard any mention of additions or changes in the training of doctors that might, medical school differences, that might make a difference in what we're talking about.
Gerard, do you have any thoughts of that, having watched it both Europe and here? And why don't you pass the microphone back? All right, front and then back. Yeah.
I think that the training of doctors is very much on specialization, of course, and the field has become so wide that specialization is required. So I don't see a way around it. I think it's more in the system and in the incentives. I don't see so much that we need to change the way doctors are being trained, at least not from the perspective that we are coming from.
I think you've hit on a lot of incentives go in one direction, but one of the things, certainly when I was in medical school, we did not get trained in, for example, communication with our patients, or negotiation, which I like to point out, every interaction with a patient is really a negotiation to get the patient to do certain things. I do think that medical schools are going to have to change how they train people and how they interact. There has been some change in trying to get medical students earlier on to intersect with patients and to relate to patients. So when I was a medical student, we didn't really begin talking to patients until we had been there 18 months. Now it's virtually day one. But I think there are lots of skills that we don't teach doctors that they really do need to have in terms of intersecting with patients. And part of that is medical schools are incredibly tradition-bound, incredibly difficult. You have to get a lot of agreement before you can make changes in the medical school curriculum, because students apply to lots of medical schools. You can't have one going off in one direction. And that, as you might imagine, with 126 or 28 medical schools, is a very slow process. And most people who become deans don't get there by being innovative educators.
Yes, sir, and then pass it to
they asked that Stan, I'm not sure why. I'm Bruce Bodak on Blue Shield of California. I know Zeke can't comment on most of what I'm going to say. I've really enjoyed the panel. In a sense, you're really all talking about high-class problems, though. There's 50 million people in this country that don't have access to any health insurance at all, which means they often don't have access to health care. And so in terms of just dealing with that issue, which of course health reform is promised we will deal with, and dealing with the cost side of that, I'm wondering, when you look at the technology that you're thinking about inventing, and when you think about adding services to deal with the issues, which incidentally I think the team approach, I think adding mental health services and high-touch services are absolutely critical to better health. But we've believed for a long time that we've got to face the fact in this country that if you want to take care of 45 to 50 million people, it's going to cost you some money.
Right.
And
why don't we let
and to do that, I'd like to hear from you all. What thoughts do you have about introducing technologies that really are less expensive?
Okay, why don't we have Gerard talk about introducing technology less expensive, and if you'll pass the microphone back to the woman in red. Thank you. Yeah.
I think it's not so much about introducing technology that's less expensive. We introduce the technology that is required, that's appropriate to do the job, to help the doctor take care of the patient. And I go back, in Europe, in my country, we have universal access. Everybody is insured. Everybody has access to healthcare, and it's costing us 9% of GDP. So it can be done. Also with today's technology. It's a matter of how you design the system and what the incentives in the system are and how the system is being run.
But
yes, ma'am, with the microphone.
Wait.
Sorry.
Yeah. Physician income is also driven by the number of things they do. So it's not just that we're paying doctors a lot more. So I don't think that there is a sustainable way to get all 50 million uninsured people in the system unless we attack the cost problem. So these are not two separate problems. We can focus on cost here, we can focus on coverage there. We have to do them together, because even if we, as has been said by the president multiple times, bring in 50 million people into a system which we know pretty clearly works not perfectly well, is broken in many ways, that would be a disservice. Plus, it's not sustainable. If we keep on the cost growth curve, it's not sustainable. So we have to actually attack these problems. I don't think they're high-class problems, as you said, Bruce, for the following reason. I do believe that everyone needs to have one of these primary care docs who is going to manage their care, and I don't think that's going to be, in net, a big coster. That actually, done right, is going to actually be a key element, especially in terms of chronic disease, of trying to keep the costs under control. So I think we can find the right combination, but I would emphasize what you said. This is mostly a problem of the structure of the system and the structure of the incentives, and that is going to have to change, and that is going to change how doctors, hospitals, and all other elements in the system actually operate.
Yes, ma'am.
Jan Hamilton, Louisiana State University, Pennington Biomedical Research Center. We know a piece of data is that the high cost of the last few weeks of life, 80% of our healthcare dollars are spent in the last 3 months of life.
False.
Okay.
False.
What
Erase
is it?
that fact from your mind because it's not a fact.
What is the information?
Okay.
What's true?
This is one area I'm an expert on before I came to OMB. So I was a bean counter in this area. At best, about 10 to 12% of the healthcare dollars goes to the 1% of people who die in that year. So 10 to 12% of the dollars are for 1% who die in a year. It's not 80%. That's a false figure. That's just garbage. It couldn't possibly be true. So we do spend a lot at the end of life. And there are ways to probably reduce that. And my own suggestion for that would be threefold. First, we need to train doctors and nurses in better communication. They need to be able to talk to their patients about it. Second, we need more and better palliative care services and things like Pathfinders to get patients better, higher quality care at the end of life. And then we have to provide the system an incentive to actually use those services rather than to give the next drug or to give another procedure. And I think that will dramatically. No one has proven it. No one's done the study that's shown it. But I do think that will actually make a change.
Okay, well, trauma care in our country is excellent, and we agree on that. However, I sense that building the immune response, we have many unknown conditions, bioterrorism, the swine flu, I could go on. What are we doing in our healthcare world in order to build the immune system to resist whatever microorganism comes our way?
Let me get Gerard in on that. Do you? You don't do immune systems?
I'm not.
Okay,
He's not an immunologist.
I thought Phillips was going to develop some electronic immune system enhancer.
Well, yeah. As far as respiratory diseases, we can help you a little bit with that. But beyond that, I would be out of my depth.
Well, look, the immune response is not a nonspecific response. One of the things that is happening is we are developing vaccines precisely for targeting these microorganisms that might afflict us, and microorganisms that do afflict us, and to reduce their severity. But it's not just nonspecific, enhance the immune system. Plus, we should be aware that a lot of the diseases that we have are from hyperactive immune systems. Rheumatoid arthritis, just to take an example, or myasthenia gravis, or lupus, they're overactive immune systems. So the idea that you want a really active immune system, everything in the body is a fine balance. And the idea of just revving something up is probably a big mistake.
Eric Landler, he was here earlier. Is Eric, you still here? Has a great panel on that because in the end, the sequencing of the genome will help on many different ways. Last question, sir.
So there is a fact that 75% of all serious psychiatric illness starts before the age of 24, and 50% of it starts before the age of 14. And I know you don't want to make a comment about mental health, but the fact that the majority of children and teenagers in the United States do not receive psychiatric care when they are ill does cost us a lot of money, if not in the medical system, then the juvenile justice system and in other places. And that has to be taken into consideration when we come up with a new healthcare reform.
Well, I won't talk about that directly, but there is some the president has been interested and on the campaign mentioned, and there has sent up proposals to expand early childhood intervention, which is very important, especially for at-risk children, so typically children below the poverty line. And I think that is going to be an area that you're going to see some serious attention to, and I think that's an area that we can forestall mental illness and other situations by intervening in these kids very early on. And by the way, you know, most of the interest in these early childhood interventions have been driven by bean counters, people like Jim Heckman at the University of Chicago, Nobel Prize winner in economics, and Art Rolnick at the Minneapolis Fed, who've all shown that the ROI, the return on investment for early childhood intervention, is tremendous, 15, 20-fold. So from a societal standpoint, that's definitely where we should be investing resources.
Tina, any final thoughts? Something you didn't get in, something you wanted to say, and I'll ask you too, Gerard.
I'm so grateful for everybody here in terms of the participation, in terms of the questions. So I'm just...
People are going to be coming up to you afterwards. You'll be getting a lot more questions. Gerard, any final thoughts?
Well, I think that was a great discussion and another incentive to just continue to do what we aim at, that is help doctors provide better outcome for their patients. If we can succeed in that, we'll make our contribution.
Thank you all very much.
You.
Appreciate it.
Very good.